So let me begin with that. Jeff, you mentioned that we cannot use the IOP, the risk factors, the appearance of the optic nerve and the visual field to differentiate between normal tension glaucoma and primary open-angle glaucoma, but we could use in the future precision medicine to do so. It is interesting that both you and Lou, the first and the last speakers of the session, address the concept of genetics and precision medicine as tools we will have in the future. So can I imagine going to my local pharmacy and buying a test that will tell me if I have glaucoma, if I will progress, if I will respond to certain medications or will need surgery? Is this fantasy or will this be real? And if so, how close are we to this? Is Jeff? Jeff is not here.
I don't think we have Jeff at the moment, Fabian.
Okay. Okay, let's keep Jeff and Makoto. Can you go ahead?
Yes. So thank you very much. I'm very glad MTG is focused on this presidential symposium. I understand IOP lowering is so anyway effective for normal tension glaucoma. So I have a question for Dr. Jonas. Thank you very much for excellent lecture. So how do you think our Asian normal tension glaucoma patients has low CSF pressure or has a fragile lamina structure, so such as myopia? So because we have a lot of normal tension glaucoma and also with high myopia. Both?
Yes, first, if you go into the non-highly myopic group with, let's say, axial lengths of less than 26.5 millimeters, there are clear demographic differences between East Asians and, let's say, US Americans, particularly in terms of obesity. And the low degree of obesity in East Asians may perhaps be associated with a lower CSF pressure as compared to US Americans, and that perhaps may be associated with a higher prevalence of so-called normal intraocular pressure glaucoma. Second, in the highly myopic group with an axial length, let's say, of more than 26.5 or 27 millimeters, the whole anatomy of the lamina creplosa changes with the stretching, lengthening, and thinning of the lamina creplosa, with the development and enlargement of parapapillary gamma zone and delta zone, and this probably will change the whole biomechanics of the optic nerve head. So that the, let's call it, normal intraocular pressure highly myopic glaucoma may perhaps be different from the non-highly myopic normal intraocular pressure glaucoma. But this is still in discussion.
Thank you very much.
Jeff, we have Jeff here. Jeff, you are muted. I don't know if you heard my question. Otherwise, I can repeat it.
Could you repeat it? I got in late.
Yeah. Actually, my question is that you and Lou alluded to genetics and precision medicine as tools that we will have in the future. So my question is, can I imagine going to my local pharmacy and buying a test that will tell me if I have glaucoma, if I will be a rapid progressor, or if I will respond to certain medications or need surgery? If this will be possible, and if yes, are we close to this or not?
So I think that there is the short term, the intermediate term, and the long term when it comes to genetics. So in the long term, I think you're correct. We'll be able to do that for many diseases. So maybe our children will be able to do that, but the next generation of ophthalmologists can tell their patients to go to the to go to the pharmacy and have imaging and the genetic makeup done at the same time and be screened for all sorts of diseases. Right now, I think that we do have options, though. We can ask our patients a detailed family history. There are numerous genetic defects that are now known, and using the genetics information we have today, we can isolate the genetic predilection for those patients and perhaps understand which patients are at higher risk for progression or developing the disease. Probably in the intermediate term, there'll be tests where we can look at the genome and get risk factors, and perhaps using a variety of different genetic defects and loci to combine them into one kind of risk profile for a patient to better understand what the future rate of progression will be at the time of a single visit, rather than having to collect this data over a very long period of time and then kind of calculate what the rate of progression will be. I think that'll be a boon for our patients.
Thank you. Neil.
Well, I just want to say what a fabulous session, and I have a question for Professor Park.
I'm Louis Pasquale.
It was fascinating to learn about all of the different risk factors, the autoimmune, the blood-brain barrier. But the one thing that we spend a third of our lives doing is sleep. And your studies are very interesting, and I would like to know whether you offer any specific advice to your patients with normal tension glaucoma regarding how to sleep and what that advice looks like.
Oh, Neil, thank you very much for your excellent question. The sleep position change is involuntary during sleep. So we may not ask patient to sleep in this position or that. It's impossible. But one point is sleeping. Some patients, some normal tension glaucoma patient in my clinic, they sleep in prone position. So in that case, I ask them not to induce your sleep in prone position. If they sleep in prone position, their eyeball will be compressed against the pillow. But some patients, they prefer they start their sleep in lateral position for some reason because of their back pain or shoulder pain or something like that. In that case, they need to treat their problems in orthopedics or other department to treat that. And I ask them to sleep in equal right or left, but it's totally impossible. But one important thing is I ask the patient who habitually sleep in